in terms of kind of infection testing, but in men, the only difference is I would also, because you get much better yield from prostate secretions and semen samples.
This is part 3 of our interview with Dr. Sachin Malde. You can watch part 1 on bladder installations and part 2 on fulguration and bladder cancer on our channel. For this part of the interview, we'll be covering questions from our audience on UTI and male anatomy. We do have a number of community members who are males and have sent in a bunch of questions for this segment. But first of all, how common is recurrent UTI in males?
So recurrent UTI in men actually is relatively uncommon. Especially compared to women, where it's much more common. In younger men under the age of 50, we think it's actually kind of less than 1% of men would have urinary tract infection. So it's quite rare. As you get older, especially elderly men, there is a higher risk of infections, normally up to kind of 5 to 10% plus because of prostate enlargement. And in all men, as the prostate enlarges and affects the way the bladder empties, that can then trigger or increase the risk of urinary tract infections. And so we see it, rarely in younger men, more common with age.
Are there other risk factors aside from age for UTI in males?
I mean, there are some other risk factors. Difficult to, when we look at the evidence as such, it's difficult to really pick that out, and it's not always kind of borne out by the evidence. But actually, aside from age, we know that sexual preference, for example, is another potential risk factor, especially anal intercourse. Just with the organisms in that area can increase the risk of infection. Like I say, the evidence is weak, but there's definitely a risk factor. And other things are other conditions that affect the immune system. So HIV, diabetes, if people are on steroids for some reason, then that can also increase the risk of infections. And in some younger men who are diabetic, for example, whose blood sugar levels aren't that well controlled, we tend to see infections developing.
And what are the symptoms for UTI in males, and are they different from those that females experience?
I think generally the symptoms are very similar. The classic symptoms of burning or pain on passing urine, frequency, suprapubic pain, urgency, they're all very similar, men and women. I think the extra thing with men is because of the presence of the prostate and often organisms originating from the prostate or embedding themselves in the prostate, so-called prostatitis, they may also have other symptoms like perineal or anal or scrotal pain and penile pain. So I think they're the kind of extra symptoms that men kind of typically get. In elderly men, I think it's more difficult, as in elderly patients generally, because they may not have typical symptoms. They may just present with confusion, or, delirium, or falling over, for example.
That's a big topic for us too. I don't think there's a lot of research into those types of symptoms in the elderly, and they're often misdiagnosed when it is actually a UTI causing that.
Yeah, and I agree with that. I think it's a big issue, especially people who are in nursing homes, people who are chronically catheterized. It's quite difficult to make the diagnosis.
And so why is it that UTI in males is often considered automatically complicated where it is not in females?
I think that's to do with the kind of anatomy of the male urinary tract compared to the female. We all have normal defense mechanisms, men and women, lots of different defense mechanisms against infection. And one of those in men especially is the long length of the urethra compared to women. And one of the theories of why infection develops is that we think the bacteria kind of ascend from outside through the urethra up into the bladder. So in women with a shorter urethra, it's more likely to happen compared to men who have a long urethra and kind of the opening of the urethra is placed quite away from the anal area and the perineum. So I think anatomy is one thing. The other thing is prostate secretions and glandular secretions in men kind of wash through the urethra and have some antibacterial activity, so that is also kind of another protective factor for infection. So I think that's why if men get infections, typically it's considered complicated.
Is the prostate considered to be part of the urinary tract? And if not, why does it fall under the specialty of urology?
So I think it's a good question. So urology deals with what we call the genitourinary system in men. And so it includes the urinary tract, kind of the kidneys, ureters, bladder, urethra, and also the genital organs, which would include the testes and the prostate and the seminal vesicles. So the prostate comes under a kind of genital organ, which is why it's covered by the specialty of urology. In fact, prostate diseases are probably one of the commonest things urologists generally would see of different kinds. So it's a big part of urology kind of care.
I note that the female urogenital tract does not fall under the specialty of urology in the same way. Can you talk a little bit about how much experience urologists typically have with female urology and urogenital issues?
So I think in terms of the urinary tract specifically, then urologists generally have good training in terms of bladder diseases. But in terms of the female genital system, we're talking about kind of vulva, vagina, cervix, uterus, and diseases of those organs. Actually, within urology generally, we have much less training in that compared to what we have in male genitourinary systems and male anatomy. Typically, if, in the UK, for example, the kind of specialist training is around five years or so. And some training is devoted to the female genital system, but not a huge amount, unless you kind of specialize in what we call functional urology or female urology, which is, for example, what I specialize in. And then I've done an extra couple of years of fellowship training, specialist training, to learn more about kind of female genital system diseases and problems. So I think not all urologists, for example, would have that experience or expertise depending on what their specialist areas are.
I think that reflects the patient experience of seeing urologists too. It really matters if they've had training in female urology, whether they can help or not.
Yeah. I think it's I think that obviously the female urinary system and genital system are very closely linked, and I think if people are having big problems with the bladder, for example, you need to be able to take into account other things around it to really give a full assessment.
Yeah. Well, since we are talking about UTI in males now, let's get back to the prostate and how it can contribute to UTI.
So I think the commonest way, the thing we kind of all would kind of agree on is that the commonest thing is that the prostate enlargement over time, as the prostate in all men, it's kind of a natural process. As the prostate enlarges, it affects the way that urine is drained out from the bladder. So it can make it harder for the bladder to empty, and it can increase what we call the residual volume. So the amount of urine left in the bladder over the years can slowly go up, and that urine that then kind of sits in the bladder acts as a source of focus for infection to form. So the commonest way the prostate is involved is that enlargement over time causes incomplete bladder emptying and therefore can lead or increase the risk of infection developing. But kind of physical restriction. But there are other ways the prostate and the kind of outflow, the pelvic floor area, can be involved in causing infection, especially in younger men. Firstly, the prostate itself could be the source of infection. So the prostate gland, just as we see embedded infection in the bladder, you can have embedded or chronic infection in the prostate, what we call chronic bacterial prostatitis. And so that can act as a focus again for chronic infection developing. Secondly, if the pelvic floor doesn't fully relax when men are trying to void, or if there's some tension or overactivity of the pelvic floor, then that can also affect the flow of urine and can cause reflux of urine back down into the prostate and the prostate ducts, and can cause either bacterial prostatitis or a chemical irritation, or kind of chemical prostatitis.
What do you think the likeliness is of having a prostate infection due to chronic UTI? Do they often go hand in hand?
So in men, I see, especially younger men, I do tend to find actually that, I mean, there are some men where the bladder is definitely the source, and actually it's an embedded bladder infection, but most men actually, I would say, it tends to be the prostate. Okay. It tends to be that the bacteria have probably originated from the prostate and are causing these chronic symptoms and chronic infections. And on top of that, on and off intermittent bladder infections. But it tends to be in younger men, the prostate is the main source.
Okay, so infection can cause chronic prostatitis, but what other causes are there for inflammation of the prostate?
Yeah, so prostate, bacterial infection, we call it chronic bacterial prostatitis. But as you say, you can get inflammation in the prostate and symptoms that are not related to bacteria. I think similar to the situation with bladder, I think we have to be quite confident we've excluded infection before saying, okay, this is a non-bacterial prostatitis. But I mean, in some patients, we do see that we can't find any bacteria even on extending testing, and there are different reasons for that inflammation. It could be, a response to a previous infection, and now the immune system remains kind of overactive, or the nerves are very sensitive, or it could be a chemical irritation, so chemicals in the urine kind of refluxing back into the prostate ducts, causing chemical irritation and inflammation, rather than bacteria itself. It's just the irritant chemicals in the urine causing it.
Okay, can you explain benign prostatic hyperplasia and possible treatment options?
Yeah, so benign prostatic hyperplasia is the term we use to diagnose men who have enlarged prostates that is not due to cancer. So it's a benign process. The prostate has enlarged and it's non-cancerous growth. It's very, very common. In fact, all men at some point will develop some features of benign prostatic hyperplasia if you took biopsies of their prostate. But clinical symptoms don't develop in everyone. We use the term benign prostatic enlargement to describe it when people have symptoms, and it's testosterone based, so it happens in all men because of just normal testosterone hormone causes the prostate to enlarge. Definitely one of the commonest diseases we see, and typical symptoms it can lead to are difficulty emptying the bladder, poor flow, difficulty getting started, waking up at nighttime a lot to pass urine, going very often to pass urine. So a range of symptoms, sometimes blood in the urine. And there are lots of treatment options, actually. It's a very well-studied area. There are lots of medications we can use to shrink the prostate or relax the prostate. And there are different surgical options now, from very minimally invasive minor procedures to kind of more advanced or more effective options. So there are lots of options for men with enlarged prostates.
Those kinds of medications you just mentioned to reduce the size of the prostate, is that something you need to take forever, or is it temporary?
It does tend to be something you take forever. Okay. There are two types of medication. One kind of works very quickly and just relaxes the prostate and improves flow, and another type which actually shrinks the prostate by around 30% or so. The one that shrinks the prostate does take up to 4 or 5 months to really start to work, and it does tend to be one of those that you take long term. If you stop taking it, then symptoms over time will return.
Okay. And when it comes to UTI in male patients, do you use the same approach to testing and treatment that you would for a female patient?
I do. So with infection in men, I think much more keen to make sure we're not missing any underlying kind of issues with the prostate or with the pelvic floor. So I think it's really important to evaluate the voiding with flow testing or urodynamic testing to know that actually the flow is normal, that there's no pelvic floor disorders. But in terms of kind of infection testing, I also recommend the standard test of urine testing and extended urine testing. But in men, the only difference is I would also, because you get much better yield from prostate secretions and semen samples. So I always recommend a semen culture. Sometimes you can even do extended analysis on semen cultures if we don't pick up anything on the normal culture. And some men, if we're not finding anything, have what we call a prostate massage to try and release some of these secretions that we can then send to the lab for analysis.
Given all the fluids pass through the urethra for these tests, do you think it can accurately pinpoint where the infection is, or does it just give you kind of more of a picture?
Yeah, it's a good point. And actually, people have looked in the past at what we call localization studies. And they're kind of the classic description is of what we call the four glass technique. Most people tend to do now a modified technique, but essentially it's a way of trying to localize where the infection is coming from. So we take different samples. We take normally the first voided sample as one separate specimen. We then take a normal midstream urine culture. Then we take some prostatic secretions, and then we take another culture after the prostatic secretions to try to identify, is this a urethral cause, is it bladder, or is it from the prostate? They're not always 100%, but it can help a little bit, especially in combination with symptoms, determine where the infection is coming from. And especially with urethral infection, men, symptoms can be quite specific, especially in men with urethritis. It's very much urethral specific rather than perineal or bladder.
When it comes to antibiotic treatment of prostatitis for bacterial infection, how does that differ from bladder treatment? I know that not all antibiotics can penetrate the prostate and that durations of treatment might be different. How do you approach that?
Yeah, I think it's absolutely true. I think it's, especially for prostatitis, it's quite a difficult tissue to penetrate. And like you say, not many antibiotics do penetrate well. The commonest antibiotics we use are the fluoroquinolones, like ciprofloxacin, or tetracyclines, like doxycycline, and more recently we've been using fosfomycin. I think these antibiotics do tend to work very well.
Okay.
Of course, with the fluoroquinolones, there are other issues and side effects. We try to avoid those if possible, but normally I've been tending, especially recently, to use something like doxycycline or fosfomycin. But you're absolutely right, it does take a long treatment course to really try and clear symptoms because the bacteria are very embedded. It can take a long time. Initially, I would normally recommend at least a 4 to 6 week course to assess symptoms before then determining whether we still continue with that regime or not.
Are antibiotics ever injected directly into the prostate for treatment?
It's another good question because it's actually something I was looking into recently. I'd say the short answer is no, in that no one really does that at the moment. But actually, interestingly, in the past, again, studies have been, and it's kind of decades ago, the studies were published on direct injection of antibiotic into the prostate, and the results were again variable, but in some patients, was very effective. So I think it's one of those things that may, if with further study, may even come back into practice for very difficult to treat cases. But yeah, I mean, the evidence is weak, and it's not a kind of recommended option at the moment.
Okay, so more research that needs to be done.
Absolutely.
And we often hear about the possibility of pelvic floor involvement in female anatomy, and you mentioned it briefly earlier too. Is that something that could be an issue for males that experience chronic infection?
Definitely, I think it is, especially in younger men. So I see a lot of men with prostatitis symptoms and UTIs who do have tense pelvic floors, or on examination, you can kind of find these what we call trigger points, very tender points in the muscles. And they really do benefit from dedicated pelvic floor physiotherapy. And whether it's, whether the pelvic floor is a primary process, whether that is the problem that's causing infection, or whether it's inflammation from the prostate that's kind of causing the pelvic floor overactivity, is difficult to know. But I think targeting both, in any case, is definitely much more effective than targeting one at a time or only one of them. So I have a very good pelvic floor physiotherapist I work with who has experience in these kind of patients.
Okay, you mentioned things that you can identify this on examination, but what about the patient themselves? Are there symptoms they might experience that could indicate there is a pelvic floor issue?
Yeah, for sure. I think the number one is urinary symptoms. So if a man, especially younger men, say, yeah, I've always had problems with my flow, it's hard to get started, it's very stop-start, takes a long time, I have to strain to go, that would suggest some kind of pelvic floor overactivity, potentially. But other symptoms definitely include bowel symptoms and sexual symptoms. The pelvic floor covers the whole of the pelvis, and so if men have bowel symptoms like constipation or difficulty emptying the bowels or erectile dysfunction, that could all go hand in hand with a pelvic floor dysfunction.
Okay, so it's very important then.
Yeah, I think it's really important to look into. It's really important that men get evaluated for that.
Okay, that's really good to know. Are hormones ever used in the treatment of UTI or prostatitis in males?
No, to be honest, I've never used any kind of hormone treatment as such for men, and it's not something that's ever done. Okay.
Do you use Hiprex or any other urinary antiseptics for male UTI treatment?
I do. So the evidence for Hiprex in male UTIs is quite weak. I think most of the studies have been done in female patients with UTIs. So we know that it's very good for female patients. And in men, I think the difficulty is just knowing how well it affects the prostate. So I think that's one issue with it. But I do use it actually in men who, after antibiotics, and we think we're kind of getting somewhere, as a longer term option to try and get them off the antibiotics long term. I have been using Hiprex, and a lot of men do find it useful.
One of my questions was going to be, do we know if it penetrates the prostate? But it sounds like that research hasn't been done yet.
Yeah, I mean, I think we just don't know. We don't know how well it penetrates the prostate, if at all, or if it's purely just working on urine, kind of passing through that area. But I think it's definitely, I think Hiprex in male UTI is definitely a kind of big area for future research.
Yeah, definitely. Are there any natural treatments that have been shown to reduce the size of the prostate?
Yeah, there are. So, I mean, the kind of common natural treatments are, there's a kind of supplement called saw palmetto, which is the big one that people use to kind of reduce prostate size, reduce prostate volume. And it can help, a lot of men find it useful and find it does improve symptoms. It does reduce prostate size. In terms of symptoms, certain other supplements like quercetin, for example, found in green tea, some people find that improves symptoms. There are other kind of chemicals around with variable evidence. I'd say saw palmetto is probably the most widely used.
Is saw palmetto another thing you would have to take long term, or can you just take it for a short while?
Typically, all of these kind of drug treatments or herbal treatments tend to be a long-term thing, because the underlying process is that the prostate is constantly growing anyway because of testosterone, and so to suppress that with medication, at least, it needs to be a long-term solution. But like I say, for men that get side effects or don't want to take medications long-term, nowadays there are lots of other options, even the minimally invasive options, to try and reduce prostate size or improve symptoms without the need for medication.
Can you cover some of those?
Yeah, absolutely. So, I mean, for prostate enlargement, there are kind of, over the last 10 years, 10, 15 years, lots of techniques have been developed. One option is actually to cut the blood supply to the prostate. So we know that in older men, the prostate doesn't really do a huge amount. It's not kind of needed for us. And so blocking the blood supply essentially would kind of cut off oxygen to the prostate, and over time allows the prostate to shrink in size. That's called prostate artery embolization. So it's a minimally invasive procedure. It's done under local anesthetic by radiologists who kind of block off the blood vessels with X-ray guidance. And it can work well. There are some other treatments using steam, for example, to where we, under a short anesthetic, we can put steam into the prostate, which over time kills off prostate cells and shrinks the prostate down. And there's another treatment which involves putting kind of like little staples into the prostate to kind of staple it apart, so it takes the pressure off the urethra so that symptoms can improve.
Right.
All of these can be done as a day case, even under local anesthetic. So they're kind of very minor procedures.
Yeah, sounds like there's a few options for people to consider then.
Absolutely.
Moving on to the urinary microbiome, is there a microbiome in the male urinary tract? And if so, how does it differ from the female urinary microbiome?
I mean, yes, definitely there's a microbiome in the male urinary tract and genitourinary system. There's lots of studies actually looking at microbiomes in women, healthy women with infections, postmenopausal women, less so in men, less studied in men, but there are studies that have compared the microbiomes between men and women. And most studies actually say that the kind of overall microbiomes are quite similar, apart from a few differences, which is mainly that in women you have higher amounts of lactobacillus, or certain lactobacillus species, compared to men. But overall it's quite similar to the female microbiome. There are studies looking at the male microbiome and its role in chronic prostatitis, pelvic pain. But I think these are quite early studies at the moment, similar with the female microbiome research. To know kind of how relevant it is.
Do you find that the UTI causing organisms identified in male patients are similar to those in female patients, and the same for bacterial prostatitis?
Yeah, I do. To be honest, the very, very commonly it's the kind of enterobacter type bacteria like E. coli. In fact, E. coli is probably the commonest cause. But Pseudomonas, Klebsiella, and Enterococcus. After that tend to be the kind of classic, even in men. And again, very similar to what I see in female patients.
Okay, interesting. And we know that organisms can pass back and forth between partners during sex. Does that also mean that UTI-causing organisms could be transferred between partners?
Yeah, I think that's a really important question, because I mean, a lot of patients, men and women, report that actually their infections are always triggered by sex, and sometimes it's with a specific partner that they get it, but they didn't have it with someone else, for example. And there is increasing evidence that the organisms found, for example, in the female vagina or vaginal swabs, is the same as that found in male cultures or male swabs. And so I think there are a group of people for whom these bacteria do pass back and forth. And I think it's important clinically, because I think it's important to find out about, when seeing a patient, man or woman, whether the partner has symptoms, whether the partner's had any testing done. And if it's very classically linked to a specific partner, I do often recommend testing the partner as well. It's often hard to justify treating the partner if they're completely asymptomatic. I would normally recommend that kind of around the time of sex. For example, the male kind of retracts the foreskin, cleans on the inside of the foreskin, trying to reduce the risk of any organisms passing back and forth.
Okay. So a couple of natural or non-antibiotic approaches that we just want to cover. Are there probiotics that have been shown to be more helpful in males, or do you think that we might find that's the case, as they are sort of showing with females?
It's a good question. I do use probiotics even in men, especially if they're on antibiotics. I kind of advise them to use probiotics. The evidence, again, is very weak. There's not a lot of evidence for probiotics in men, and how effective it is. We know that, in microbiome studies, we know that lactobacillus is present in high amounts in healthy individuals, even in men. And we know that does go down in people that have prostatitis, for example. They have lower levels of lactobacillus. So it seems likely that replacing that or replenishing that even in men would improve things. But I think the evidence is very weak. But I do recommend it.
Okay, and what about D-monos? Have studies been done for use in males, or is that also something that's much more done in females?
Yeah, unfortunately, with all of these treatments, because it's so much more common in females, all of the studies are done in females, and we kind of extrapolate that to males. So a lot of male patients will use D-mannose, works specifically for E. coli type infections. But I think the clinical evidence for it is, again, very non-existent.
And the last one is UTI vaccines. Do you know if these have been studied in male UTI?
Some of the vaccines have been studied. I mean, a lot of the studies are mixed populations. So they include a majority of women, but there's some men in the studies as well. And so if you look at the male data specifically from those studies, although they're low numbers, they do still report good success rates equally in men as in women. So I think it's something that could be considered in men, even though the evidence is weaker for men because overall the number of men it's been used in is much lower. But some of the studies do report some successes. I think it depends really on where the infection is, whether it's the bladder or prostate infection, and what the organisms are. But for example, the newer vaccine, the Uromune vaccine, there is some evidence that in men, the kind of success rates are equivalent to that in women.
Are the vaccines something that you have been utilizing in your own practice?
So we have been using it in select cases, mainly Uromune, the sublingual spray, for some people who are really keen to avoid antibiotics, who want non-antibiotic options. For people with recurrent infections rather than chronic infections, I think it can work quite well. So we do tend to use it in selected people.